Yeah, with that, I think we'll go ahead and start. John, how are you?
I'm doing well. How you doing, Tim?
I'm good.
Good to see you.
Good to see you as well.
Could you hear
So
me furiously scratching notes?
I know I told John you can always tell somebody's pretty legit when you can hear their pen on the paper through the microphone. They're over there taking notes. So
Legit or ill-prepared, like
well,
preparing at the last
I
minute?
was trying to give
No.
you a little bit of
And I'm
credit. So
prepared, but just continuing to shape and to mold. That's what I'm doing. It's just the
always shaping and
sculptor,
molding.
always going back and doing the finishing touches.
I love it.
Thank you.
Well, thank you for being in here with me today. I brought you in. You're our director of creativity. If anyone has been on a past webinar, one of John's in the past, he's an amazing storyteller, but he's also been here for 25 years now.
This is, yeah, my 26th year now.
26th year.
I'm almost a QLI half-timer, which is like, I was thinking that there's a point where you've been at QLI for half your life. I think in 3 years, I'll be a half-lifer.
That is very true.
Yeah.
That's amazing. Well, you are extremely influential in a lot of things around here. And throughout your 25 years, now your 26th year, worn a lot of hats. And so I think bringing you in to do an introduction for Jim, you can, better than a lot of other people around here, tell the journey of Jim and how he landed to be our medical director. And so I don't know if you could briefly talk about Life Path Services at QLI and your introduction to Jim, and then segue into having a conversation with Jim.
Definitely. I know it was in the summer of 2009. And so in the Lead Life Center at the time, it's what's now become what we call our Life Path program. And in a nutshell, the Life Path program is really taking a look at every individual we serve and taking a close look at their lives. And it is very individual inspection of just what it is that they value, what's most important in the world. And that what is typically who, their families, what they do for a living, their friends, their coworkers, and then of course doing an assessment of whether it's a catastrophic injury or an illness that has befallen them, and taking a look at how that has impacted their life. And the big part of it, and I call this the art of rehab, is trying to use creativity and innovation and help them see a future that's worth living. So in 2009, we had an opening, and a young, bushy-haired college student came in, a pre-med student named Jim Colt came in and did an interview. Now, I know Jim and I have joked, he remembers distinctly some of the interview questions. I don't remember specifically any of the questions that I gave him, but I do remember the feeling that I had after he left. And somebody asked me how'd the interview go. And I said, well, Jim says he wants to be a doctor. And I can tell you that not only he will be a doctor, he'll be a damn good one. And I just knew that because of his focus, his intellect, but mostly I was struck with his compassion and his listening skills and just his social skills. That there was just all the makings there of a really, really good doctor. Well, of course, Jim was here for a while, then medical school demands, and then getting married and starting a family, and all of those things pulled him away from QLI for a while, until in 2018 he came back, and as part of an elective for his residency, he was helping with our adaptive sports program. So we had stayed loosely connected throughout the years, but now we were actually reintroduced to almost Dr. Cold at that point. And the stars had aligned at that point. Our CEO was just thinking, gosh, we will be looking for a medical director, and I wonder if that's something Jim might be interested in. And in 2019, in August of 2019, we were so fortunate to make it official that it worked out that Jim had completed his medical degree in, he is a doctor of rehab, and help me out here.
He's a PM&R doctor.
PM&R, that's it. Jeez.
Jim,
it's on my
he flipped the page.
He is a doctor, trust me. Yes, I did flip the page. So he had completed his doctorate in physical medicine and rehab. So it really was a case of the stars aligning.
Absolutely.
And that Pat reached out, they had a conversation, and it was one of those cases that it was an amazing fit for us. And hopefully it's Jim still finding that it's been a great fit for him. And like I said, he has that expertise in the medical realm, which, is definitely valuable, but you really strike gold when you find a medical expert who also can connect with the person and can truly and deeply listen and understand what this person's life is all about, and then work comprehensively with a team to put forth a plan to help this person forge a life that they can be excited about and they can look forward to living again. So you guys are in obviously for a treat. You're going to get a sense of all of that in the next hour or so.
Yeah, Jim, do you remember all that as well? Did he tell the story correctly?
I think he hit it spot on.
Well, other than what you're a doctor in, so that was pretty good. Other than that, and as I tell a story, I realize that the lion's share of the credit of you being here goes to me.
Yeah,
Actually.
I mean, that's why I brought you in, right? You know?
Exactly. So if it weren't for me, there'd be no Dr. Colt.
You know,
I
I
don't think so.
Prior to this webinar launching, I told Jim a story. Jim, when he was out in 2018, my dad does volunteer on campus, and he got to meet Jim. And I was telling Jim he made an impact just in those 2 weeks he was out doing his kind of elective that my dad still to this day asks about him. And I think that speaks volumes to just the type of person Jim is and why he is such an amazing fit to be our medical director here at QLI. So with that, Jim, I think we'll hand the mic over to you and have you take it away.
Well, thank you guys so much for such a humbling and nice introduction here. It has been an absolute dream come true having the opportunity to be able to collaborate and work here at QLI for almost the past 2 years. It's truly one of the most unique rehab settings that I've ever had the opportunity to be a part of, and it really is a very special place. I think just like how mission driven it is. And as John was talking about, the life path services, I think is something that really makes QLI a unique place to work, where so much of what we do is really tied to that purpose in people's life and helping them not only gain the independence, physically, cognitively, emotionally, but really integrating that into what are those kind of next steps forward in their lives. And so, it kind of brings us into one thing that we commonly come across, with a lot of our residents here at QLI, are issues with tone and spasticity, which is in part why I chose kind of this topic specifically. There's several different kind of pieces that I want to touch on spasticity. It's a pretty broad topic. This is my first time giving a webinar. And so as Tim said earlier, I definitely am more conversational kind of in my presentation. So we will, be kind of having that chat box open, and feel free to kind of bring in some questions, and we'll try to get those answered. And then we'll have some time at the end too for questions and answers as well. I think when I was kind of putting this lecture together as well, it's just recognizing that we all have very different backgrounds and just trying to meet people where they're at. So if I'm not trying to talk over or under kind of anybody, but just, lay the groundwork for with spasticity management, what is spasticity kind of for starters, and then a little bit about some of the different management options. And hopefully you come away with a couple of relevant kind of pieces of information that can be helpful, when you're helping guide and other people's treatments. So, just kind of, I don't have any disclosures, no financial disclosures, no conflicts of interest at all. And so we'll kind of get started here. So spasticity, it's actually a very specific kind of topic that I do want to address. I think the broader kind of overarching area would be upper motor neuron syndrome, which is a collective term referring to different types of motor behaviors that patients will experience after injuries, injuries to their brain or spinal cord. So it's actually spasticity itself is really the end result of what we're seeing in the muscles, but it's actually caused by injury to part of the central nervous system, which is specifically the brain or spinal cord that controls the voluntary movements. And so, you can also see spasticity after central tumors, strokes, multiple sclerosis. So that's really kind of what this is focusing more on, as opposed to a muscle spasm or just muscle tightness. And I'll go into some of the other kind of terms that are associated with upper motor neuron syndrome. But again, this will be predominantly focused on spasticity. And so kind of the textbook definition of spasticity is the involuntary velocity dependent muscle tone. And I emphasize that because that is what will differentiate spasticity from other types of motor behaviors that you'll see when the central nervous system is injured. And so the damage from the injuries to the brain or spinal cord to that central nervous system leads to an imbalance. And so you have increased excitability in the muscles due to loss of descending inhibition. And I know it's kind of a lot to take on initially. So that's why I do have kind of a little cartoon here showing what kind of the normal pathway would be. And so that's where, the brain, the white matter motor pathway starts in the cerebral motor cortex, and then comes down the spinal cord to the lower motor neurons at the alpha motor neuron part of the spinal cord. And then that's where it leaves the spinal cord and goes to the muscle fibers. And so that would be kind of the normal pathway for sending that message. And, ultimately what happens is that muscle needs to get the information from the brain, and then the muscle will send a signal back that's getting interpreted in the spinal cord as well. And in order kind of to let it know how far it's stretching and relaxing kind of the other muscles around it, so it knows how to make that movement. So it's a pretty complex process, really, just to get that normal motor, that normal muscle firing. And so what happens, in spasticity is that the injury either to, again, the brain or the spinal cord creates this imbalance where all of a sudden the signal from the brain that is telling those muscles to relax is disrupted. And so that alpha motor neuron, so the part kind of where it leaves the central nervous system and goes out to the muscle fibers, isn't getting the disinhibition, kind of the relax information from the brain. And so it creates this hyperexcitable state. And then that's where you start to see some of that muscle tightness, the muscle tone. So, just kind of in a nutshell, it's like there's, when that pathway is disrupted, the default then is going to become that muscle activation on some of the muscles and that muscle tightness because it's not getting the signal from the brain to relax. And I do go into some of that because I think it's important to understand a little bit of the background in order to contextualize what does that management typically look like. So, as far as kind of the presentation of spasticity, typically, what you'll see in folks is if you check the reflexes, they're a little bit more pronounced. Sometimes it's just on one side or, in all the extremities. There's some primitive reflexes, which when your central nervous system does have an injury, then some of those will come back. So, we'll look for Hoffman's and Babinski's. And so that's all kind of initially what we'll present. And so in medicine, oftentimes we'll separate positive and negative symptoms. So positive, kind of the increased response for the surviving neural pathways versus the negative is, some of the deficits that you see in the normal functioning, again, caused by the central nervous system injury. And so, quite honestly, the positive symptoms are more tangible, more obvious. But the negative symptoms of spasticity, in this case, so again, kind of the deficits of normal functioning, are often more profound for the functional side of the recovery. So some of the fatigue and weakness. So it's not just the muscle spasms; it's that associated weakness underlying those spasms. And so I do think one thing that comes to mind is, and maybe you could type in, are there some advantages that you've seen to spasticity, or disadvantages? I often think about, just with most things in life, there can be a silver lining, right? There's rarely something that is all bad in itself. And I do think spasticity kind of falls into that. And oftentimes we're so focused on treating the spasticity, we do have to be mindful that that we have to have a overall goal that's really focused on improving people's function. And so with that in mind, there could potentially be some advantages to some of that spasticity. So, some things that kind of come to mind with advantages on the tone is, if you had tone, let's say, in one of your legs, that might give you a little bit more extensor strength, allowing you to stand or transfer, more independently. That tone itself can also, with the muscles contracting, can improve some circulation and reduce your risk of getting swelling in the legs and deep vein thrombosis. So, it can improve some of the bone density as well, reducing the risk of osteoporosis, and maintain some of that muscle bulk. So I do think, it's like you always have to contextualize when you are, treating any specific symptom, that again, a little bit of tone is not necessarily a bad thing. It's just kind of understanding the spectrum of, is this more mild? Is it moderate or severe kind of tone? And so there are obviously several clinical problems that can arise because of the tone. And so it's that's really where, as a physiatrist, I kind of step in and try to look at the whole picture of what's really going on, what the specific goals are in therapy, for example, and how could that tone be managed in such a way that it's like, perhaps you don't want to completely lose it because you need some of that tone for the standing balance, but perhaps some of that tone is starting to get disruptive, due to pain. Maybe it's making it more difficult for doing your morning routine, like brushing your teeth or combing your hair, with some of the flexor tone in the upper extremities. Could be interfering with transfers with some tone in the trunk. And so there is certainly indications for when it would make sense to look at management of some of that tone in order to reduce the risk of some of the clinical problems. So when it comes to management, this is probably, I think, one of the most important pieces here is kind of my overall perspective on management. And that is, again, it comes down to selecting appropriate functional goals. And again, maybe this is something that you could jot down some notes about different goals that you've seen kind of over time. And then we can talk about maybe some appropriate goals with spasticity management. But I'll start with identifying patients. You really have to know your patient well, and have the appropriate patients for treating spasticity. Because again, when I'm talking about spasticity, it's not necessarily that, we're just discussing someone with some low back pain and muscle strains. It's spasticity is a very select kind of diagnoses, that patients have involving their central nervous system. So it's folks with spinal cord injuries, brain injuries, multiple sclerosis, cerebral palsy, tumors, strokes. So it has to involve really the central nervous system. And then that's what helps guide, what medications could be beneficial or other interventions could be beneficial. So it's identifying your patients and really understanding too, kind of what is their overall kind of support system look like as well, that caregiver support, because some treatments aren't really going to make sense, for example, if you don't have a good amount of support. So one thing that we can touch base on is baclofen pump management. That's one that really requires close follow-up, every couple of months to have that pump refilled. And if you don't live in a place where you have access to that, or the support, the transportation to be able to get that refilled, gosh, that might not really be something that makes sense for you. Even though it could have a functional benefit, certainly you do have to put into context if that is kind of sustainable over a period of time. So, I kind of come back to the functional goals, because I think, treating spasticity does not fall only in the realm of physiatrists. There are certainly other specialties that are also very skilled at helping treat spasticity. From my perspective, though, it's more than just treating spasticity. It's looking at, gosh, what are my functional goals? And is spasticity limiting, potentially the progress in those goals? So, kind of individualizing that goal plan, whether it's, improving a specific aspect of their gait, working with the occupational therapist on hygiene or morning ADLs, and is the tone, maybe in the bicep affecting some of their progress the last couple of weeks. And so then we need to look at, gosh, if spasticity was controlled in a different way, would we be able to make more progress in those goals? So there's either it can also be pain relief, decreasing some of the spasms frequency if that's waking them up at night. So I think it's kind of looking at a bigger picture rather than just saying, gosh, we're going to treat your spasticity. It's, I'm going to help you achieve this goal that you and your team have kind of helped set up, and how can I be helpful in you achieving that goal? And so that's what's really measuring the success of the spasticity management, as opposed to just treating tone for the sake of treating tone, because it is actually quite difficult to measure spasticity. Typically, like, spasticity has a lot of different measurement tools, but it's difficult to quantify. So the modified Ashworth is the most common scale that you'll come across for measuring spasticity. It's probably the most widely used, but these are qualitative scales typically. There is the Tardo scale as well. And I would say more commonly, some of the scales are used in research, but again, the modified Ashworth is probably the most clinically relevant scale that you come across, and then can help you contextualize the severity of the tone itself. So again, it's somewhat isolated qualitative measurement, looking at the modified Ashworth scale. So it's a 0. Yep.
We move on a little bit. We did a couple questions just more in line with the identifying the patients and diagnoses. So we had a question that come through asking, is spasticity the same as a diagnosis of dystonia?
No. So let's see if I don't know if I have I think maybe I might have skipped over a slide. So dystonia is different. So let me kind of contextualize that. So when I started at the beginning, I talked about like upper motor neuron syndrome. So there's several different presentations of that. There's different types of motor behaviors that you'll see. So dystonia, for example, is involuntary, so similar to spasticity, but it has sustained contractions, kind of more twisting, abnormal postures. And so it's not based on velocity. So it's not when the muscle is getting moved. It's kind of that more constant tightness, which and again, I don't want to kind of get into too many of the details, but you can have overlapping. So you could have a spastic dystonia where you have muscle contractions that are present at rest, but it could coexist with spasticity. So, so when those muscles are at in movement as well, seeing some of that tightness. And that would be different than like clonus, for example, which is kind of that alternating contractions secondary to the increased tone. So sometimes you'll see clonus in the ankle, for example, and someone might say, gosh, my foot kind of keeps bouncing up and down. I feel like my legs, having more tone. So all these are different types of motor behaviors that are similar in the fact that it's the central nervous system that has an injury. It's just slightly different presentations of how it affects the muscles. You might also come across, tremors fall into the same category as well. And so, Parkinson's or essential tremors, they're kind of more the rhythmic, repetitive oscillations that are not self-sustaining, kind of involuntary movements as well. And so all of these fall kind of in the motor behaviors presentation of upper motor neuron syndrome. And they can have different interventions as well. Some, are more treatable than others. There's as different parts of the brain are impacted, sometimes that's what will end up causing different presentations, again, kind of in the muscle movements. But, for, I guess, the simplicity of this lecture, we'll just try to focus in on spasticity itself. But it's a good question because often, again, you're not going to find a motor behavior that exists in a vacuum. It's, every person is unique and has a little bit different type of presentation.
Okay. I think that answers it. There was a follow-up question from the same person, just kind of saying, would the causes of these all result of a central nervous system injury or trauma? So is it always related?
Yep. Yeah. So, and again, it's like there's specific parts of the cortex if injured, or the subthalamic nucleus, the basal ganglia, that would impact essentially what the presentation of the motor behavior would be. But it's all tied into an upper motor neuron syndrome itself.
Okay. Awesome. Thanks, Jim.
Yeah. So, and, again, so a qualitative way of kind of describing what's going on with some of that muscle tone is the modified Ashworth scale. And this is the most clinically relevant and useful scale. And so I'll document kind of where different muscle groups are at based on this scale in order, yeah, and there is some inner user reliability. So that way, I can say, well, the resident I presented with a 3 out of 4 modified Ashworth scale and their elbow flexors, for example. And then we, added a medication, we changed some of the bracing, and now we're, down to a 2 out of 4. And so that'd be one way of saying if your interventions have been helpful. Again, that's, to me, it's not as important as saying, well, we added this medication. Maybe you're still at a 3 out of 4 on the modified Ashworth, but functionally you've made some progress, and you're better able to do that transfer now. That is in many ways more relevant and certainly more important for that resident, focusing in on the functional goals as well. But again, just kind of a more universal system as, residents maybe go to other providers, or when they, discharge home. So that way, another provider would understand kind of the baseline of where some of that tone is at. So I do think it's important too to recognize that spasticity can kind of be a diagnostic tool. And so, when you look at, gosh, what are the potential causes of it? We understand that it's coming from an injury to the central nervous system, but it's like sometimes you'll have someone where Monday the tone is controlled pretty well, and then Tuesday comes along and the tone is significantly worse and they're not able to transfer. And so it's kind of recognizing that there's often other contributing factors where the central nervous system doesn't quite know how to process some of the information that's coming back to it. Maybe it's kind of incompletely coming back. And so, it is having difficulty, again, controlling the overall kind of inhibitory signal down to the muscles. So, the most common kind of findings that really exacerbate or can increase that tone, the spasticity, would be infections, specifically urinary tract infections, kidney stones, sometimes a new pressure injury, or ingrown toenail, bowel impaction, and then less commonly, tethered spinal cord, some issues kind of longer term that can start to come up as well. And so I think it's recognizing that there might be initially after the injury some hypotonia, so kind of low tone, and then sometimes that can increase a little bit over time. And that's to be expected. But certainly if you had a significant increase in tone, you would you'd want to further kind of evaluate what that changes, as opposed to just increasing spasticity medications and maybe not identifying the cause. So, again, when you start to look at treatment options, I would say on the left side of the screen here, this is really where the focus comes in. And that's where, I feel so fortunate to have such a collaborative team. And, it's like I recognize that the medication and intervention side is a piece of it, but truly for, kind of the more sustained benefits, you have to have excellent therapeutic interventions. Daily range of motion for spasticity is just an absolute must. And if you're doing, just medication interventions or injections kind of, again, on its own, and not really having that follow-up with the daily range of motion, you're just never going to get the functional results that you're hoping to achieve. Most of the interventions from the physician side on the medications, for example, really, have been proven to be beneficial, on that modified Ashworth scale, for example, but don't necessarily show the benefit functionally. And so it's that combination of, gosh, can we decrease the tone, qualitatively, but then on the functional side, you have to pull in, excellent therapists that you're in communication with and understand how to make the adjustments, based on how that tone is progressing. One thing that I have enjoyed, we've had a couple of residents here at QLI involved in hippotherapy, equine assisted therapy, which can be really beneficial, both kind of the core strengthening, and then also in your low extremities, just with some of the extension tone that individuals will have. And then aquatics, we're very fortunate to have a HydroWorks pool. It's something that basically all the residents that take part in an aquatic therapies, always report that that's really beneficial. Some of the buoyancy, just the additional pressure on the limbs, and it's just really an excellent way for helping get some good range of motion, stretching, and so I'm definitely a big proponent of that. And then kind of more specifically from the therapist side, kinesiotaping, the splinting, static and dynamic splints, being sure that we have the right equipment on board. And so I think, all those, again, to me, are really the essential piece of it. And then it's like, what could I, potentially do from a provider side to also, hopefully help with the resident to achieve their goals functionally. And so, so kind of in conjunction with the therapist, you look at what are some of the FDA approved medications for spasticity. And so, that's kind of where I go to first. Medications that I understand the mechanism of action. And again, kind of going back to that, kind of how your actual reflex arc and the muscle signals are working, how does this medicine impact kind of that pathway? And so that, these are some of the most commonly used medications for, again, specifically spasticity management. And so we can touch base on a couple of those. And then we'll talk a little bit about some of the more focal management with neurotoxins such as Botox and then phenol injections. And then finally, kind of, in a sense, the more extreme side of interventions for severe spasticity that's not responding well, to oral medications, more conservative kind of management, therapies, and potentially injections where it would make sense pursuing surgical interventions. And so, as a physiatrist, my role, really lies more kind of in the oral medications and in the kind of injections. So that's kind of one area that I'll just kind of discuss through on the management side. And I think what's pertinent here is, I think as case managers, certainly you can be a really good advocate and an educator too for clients that you have that have had injuries, and maybe being sure that you're asking appropriate questions and helping facilitate some of those conversations to really help guide people where, for obviously people going through really traumatic experiences and new symptoms such as spasticity, it can be helpful just kind of contextualizing that maybe they try a medication like baclofen, for example, and it's not the right fit. There are other kind of medications, and so I think it can be helpful just kind of having a general idea of some of the medicines out there. Now, I would say oral medications, again, are for more generalized spasticity, mild to moderate kind of severity. And so, again, this is kind of our starting place. You don't always know how people are going to respond as far as adverse effects of the spasticity medications, especially as you get to a little bit higher doses, are fairly common. These are pretty serious medications, ones that you don't abruptly stop pretty much across the board. These are medications that you do kind of slowly increase and slowly decrease, because for the most part, they're working on your central nervous system, right? It's going back to where the area of the injury itself is. So, baclofen, for example, it increases GABA, which is kind of inhibitory signal from your brain down through the spinal cord. It's the preferred medication. So this is the first one, probably one that you've commonly seen for spinal cord injuries and multiple sclerosis. And over time, it's like oftentimes some of the adverse side effects, sedation in particular, is one that that people will kind of acclimate to for the most part. sometimes you start a real low dose, 5 milligrams a couple times a day, and it's just too much. And so then you have to look at some of the other options. Diazepam's been around for a while. This one, I personally do shy away from, particularly in brain injury and stroke, as it may interfere with some of the recovery. But it's really the addiction side of this, and recognizing there's a lot of pain management issues as well. And so ending up with a benzodiazepine and opioids is really contraindicated, and can increase individuals' risk of kind of that sedation, and really kind of impair some of that motor coordination. And so it would really kind of be much farther down the list. But again, it does work centrally. It can be a very effective oral medication, but you just kind of have to be mindful of the side effects as well. And then the other two medications that are commonly used in spasticity would be tizanidine. Again, works kind of more centrally and inhibiting some of the spinal reflexes. This one can lower blood pressure a little bit, similar to clonidine as well. And the challenge that you run into in spinal cord injury is often already having some orthostatic hypotension. And so you do have to be mindful, again, kind of on the side effect profile. But tizanidine has been shown in a lot of studies to be more beneficial for pain. And so if that is, one of the primary kind of goals of treating the spasticity is the pain management, tizanidine then might be one that makes sense to try. And finally, I just want to touch base on dantrolene. Not used probably as much as it ought to be. And the part I highlighted here is the peripherally acting, which means this is one that works on the muscles itself as opposed to the central nervous system. And so that's what makes this much more desirable, particularly after traumatic brain injuries and strokes, because you're not going to get as many of the sedating side effects. It has a bit of a bad rap because of hepatotoxicity. About 1 in 500, and maybe even less frequent than that, individuals do start to develop elevated liver function tests. So you have to watch that initially, and then can spread out if they're tolerating the dantrolene well. But I'm a big fan of this one, or combining it with baclofen, for example, as two very different mechanisms for addressing tone, so that you're not having to get on as high of doses potentially of one or the other, which can result in more side effects. So again, I think dantrolene is one just to kind of keep on your radar. I think it's, again, one that can be very beneficial, in particular after strokes and brain injuries, as opposed to baclofen, which can be pretty sedating too after injuries. So, and then just kind of briefly, again, clonidine, similar to tizanidine, rarely used because of the orthostatics. Then gabapentin, often you'll see this used for more neuropathic type pain, but it's like even at relatively low doses, it can be, in addition to some other spasticity medications, gabapentin sometimes can be beneficial as well. Again, you just have to watch for the somnolence, that daytime fatigue side effect that combining some of these medications will start to create. So I will say, if it's a more focal kind of spasticity that you're trying to treat, I am a big fan of trying to limit, in a sense, what we're treating. So if it's, again, specifically some tightness in the elbow flexors, you hate to take a medication that's going to affect every single one of your muscles, including the extensors of your, arm that you're trying to counteract those elbow flexors. And so if you're taking an oral medication, again, it affects every single muscle. And it can have some associated, negative side effects. And so, when it is kind of a more specific muscle group, botulinum toxins and there are multiple formulas. Botox has been around for a while, so I think it's kind of synonymous with the botulinum toxins, but there's Dysport and ZMN, Myoblock. Some of them have different FDA approvals. And again, there's really, and I'm not a rep for any of these companies. I haven't seen a significant functional difference in any of the medications. And so I do think all of them can provide a benefit, given the right patient kind of selection. What these injections do is, typically you're using kind of EMG guidance so that you know that you're getting into that neuromuscular junction area where the nerve is inserting into the muscle. And that's where you're injecting kind of the diluted botulinum toxin, which helps decrease the amount of acetylcholine that's released in the nerve going into the muscle. And what that can do is reduce that signal that's actually coming, from the central nervous system down to the muscle for several months. And so there is kind of a dose dependent response. So that's why, every couple of months, often these types of injections need to be repeated. One of the biggest drawbacks is the expense of it. But again, I think it's kind of keeping in mind, and oftentimes, soon after an injury, you kind of want to see where someone's tone's going to be, developing. It's sometimes as some of that strength comes back and coordination, some of the tone can improve, maybe doing one round of injections, and then a couple months later, it might be a different muscle group or a different area. And so I think sometimes this can be helpful when there is kind of a focal area. And again, you have a functional goal in mind. So maybe someone's not tolerating an AFO brace and you're doing some injections into the calves in order to help them better tolerate that brace, reduce the risk of skin breakdown, and start to make some more progress in the gait training or transfers. And so that's kind of the benchmark at which it doesn't make sense repeating injections, or have they progressed to the point maybe that you don't need repeat injections. So again, I think if you're, sometimes you'll have a bit of a combination, maybe there's some general spasticity, but one or two muscle groups that make sense for doing injections on top of that, and can be really helpful if there is a functional goal kind of associated with that. I'll just briefly talk about phenol, just in case that's something that you've come across, or different alcohol injections. The product itself is much cheaper, but there is a significant drawback, which is the dysesthesias, or just pain that's associated with the sensory nerve component. And so when these injections are performed, they can they kill that nerve axon, so they can last a little bit longer. It's difficult to be sure, like it's technically difficult to be sure that you're at the exact correct point. And really at this point is limited to just motor nerves. So oftentimes the nerves that are controlling your muscles, the motor side and the sensation, travel together. And so if you are going to target, a nerve, you really want to try to find one that's just the motor nerve itself. So the obturator nerve, which is for hip adduction, is probably the most commonly used time that you'd see phenol. Again, the pain associated with these injections, though, has really put them out of favor. So not something that I would typically recommend and have not, for example, in the past 2 years here. And then finally, I think when we get to surgical interventions, again, this is kind of for the severe tone. Either you haven't tolerated medications well, you haven't gotten the functional results from injections, but the key is setting realistic goals, because not every surgery can be, reversed. And so I do think, certainly there's been several times where we get to the point maybe where tendon lengthening makes sense, like in the Achilles tendon, for example, because, of difficulty, maybe getting appropriate bracing or weight bearing. But, the recovery can be a significant amount of time. and it's just being sure that, in a sense, this is kind of the last resort, and that you have a reasonable plan in place. I think one thing that I always caution on, again, pursuing any more aggressive surgical intervention, cordectomy, like removing a portion of the spinal cord, is that below that level, you're going to have flaccid paralysis, potentially lose more bowel and bladder function. And then same with the selective dorsal root rhizotomy. Again, in the right selection of patient, it could be beneficial, but you are taking a tremendous risk of losing some of the function that they have. And you take away some of that spasticity. And again, we said earlier, it's not all good or all bad. Some of those advantages of the tone all of a sudden are gone as well. So maybe they were using that extensor tone for standing, but now there is no tone. So you've taken care of the spasticity, but really left someone in potentially a less beneficial place functionally. So I think it's always, again, important to have those conversations up front about realistic goals. And in part, I see that with baclofen pumps, and this is kind of more for generalized spasticity, more in the lower extremities and trunk. And it's a direct delivery system into the CSF. And so this was one, again, where you got to be sure that someone interested in it has a tremendous amount of support. They're going to make it to all their pump refills. If that pump were to fail, it would start beeping, and that they have access to be able to, get that interrogated and replaced if needed. So most of the residents that have had pumps have been very happy with it, but you do have to be mindful. Again, this can be an excellent way to take tone away, particularly in the lower extremities. But you can sometimes lose that functional tone. And so, it's just, they'll typically do kind of a trial ahead of time. So being sure that you have a therapist that really knows the patient well, as opposed to, sometimes they'll have the therapist with the neurosurgeon just kind of assess, the tone's resolved with the pump trial. But, it's like, functionally, is that really going to be the right fit for you? So again, I just kind of, this is one of the more last resorts, but I think also reassuring people that there are options out there. So, if the injections, if oral medications aren't getting some of the goals that they've set out, that it is something that I think is worth pursuing and doing a trial just to see if that is something that would be beneficial for them potentially. And then finally, just kind of keeping in mind, as I said at the beginning, that these are, pretty heavy hitting medications, and both the overdosing and withdrawals on the medications, sometimes can be life threatening. And so, were you to have, a client or a patient that really feels strongly, gosh, it's like, my baclofen's not working at all, I'm just going to stop it. Encouraging them to touch base with a provider, kind of talking it through, setting out a weaning plan, and certainly with benzodiazepines as well, that these are not medications that you would want to just stop abruptly, or if they had issues, insurance coverage, or, just being able to get the medications, from the pharmacy, that you're sure that they kind of understand how serious it can be to abruptly stop any of these medications. So, so again, there's a lot of advantages, a lot of, and some potential disadvantages, but contextualizing what you're trying to achieve, with your intervention, and really collaborating closely with the patient, so that you're all on the same page and have some realistic expectations. So I know it was, again, a relatively broad topic, tried to cover several different areas here, but just want to open it up in the last couple minutes here if you had any other specific questions or any other thoughts, concerns that maybe I could be helpful with today.
Yeah, and we did have a few come through, Jim, that I think are I'll ask those right now before we launch the poll question. Actually, I'm going to go ahead and launch the poll question on the screen right now. So if you are looking to receive a certificate of completion, make sure you do answer those questions here. So that'll be launching on everyone's screen right now. One of the questions we had come through was, could severe burns cause spasticity?
I mean, it probably not the burn itself, but it's I guess it would depend location wise. Again, if that did end up having any contusion or impact on on your spinal cord itself, certainly it could, or if there is any associated anoxic brain injuries or anything else with the burn itself. But otherwise, that would kind of fall more into, again, some of the muscle strains. Sometimes you can get tendon shortening, so that really wouldn't quite fit. And so that's where, when you look at the interventions, there can be overlap in other areas, involving muscle tightness, but this again is kind of more focused on the central nervous system.
Okay. And then we had a question about trigger point injections, and if they would be appropriate for spasticity, along with medical and therapy,
Yeah.
therapies.
Yeah, and I've actually seen some pretty good good results, both from like dry needling and trigger point injections. The trigger points typically, involve like an anesthetic, like a lidocaine. We try not to do the steroids and trigger points anymore, but certainly, it's like if a patient's having a kind of a trigger, like where there's a specific kind of muscle group that's a bit tighter, it can kind of help reset some of that reflex arc pathway, bring in a little bit more blood flow. So I would say, I think sometimes what you run into, if you just, again, do trigger point injections and you're not doing additional therapy with it, sometimes that sustained benefit isn't there. So sometimes it takes a couple of injections really to kind of get a little bit longer lasting benefit, but definitely I've seen some good results with that.
The person who asked us said, thank you very much. That answers the question. So appreciate that. And then we did have one other question here. Actually, we got two more that rolled through. Curious about use of Robaxin. Is it helpful for both spasms and spasticity? Can it be used safely along with baclofen?
Yeah, so I would say there is a whole host of other medications that have been used for muscle strains, including Robaxin, cyclobenzaprine, or Flexeril. There really is a pretty extensive list of other, maybe not FDA approved for spasticity. For some folks, can provide some benefit. Personally, I stay away from Robaxin, again, simply because some of like the sedating side effects of it. So I kind of lean more towards medications that I understand the mechanism of action. It makes sense kind of in the actual cause of the spasticity itself. But if you're talking, maybe associated chronic low back pain, in addition to a newer injury as well, there certainly is a place. And it's like, if you go through 2 or 3 spasticity medications, again, everybody processes these medications differently, and maybe it makes sense. And if they're getting a good benefit from it, by all means, that's kind of the end goal, but would not be probably in my top 3 medications to start with.
Okay.